Mayo Clinic presents the Always On EM podcast, hosted by Alex Finch and Venk Bellamconda. Hello, everybody, and welcome to Always On EM. My name is Venk Bellamconda.
And I'm Alex Finch.
Welcome to the September episode of the show. We're really excited that you've been joining. If you haven't caught some of the more recent episodes, you will be a little surprised that we have switched from doing 2 episodes a month to 1 episode a month. And of course, part of it's a little selfish. I have to admit that both Alex and I have amazing children and spouses that we want to spend a little bit more time with, but also it is because of you. We want to make sure that we give you really high quality content. And so we're going to spend a little more time focusing on trying to get the best speakers and topics for you without feeling the rush of trying to create something new every 2 weeks. I hope that's okay. We'd love feedback on how you feel about it. And if you miss having more content, please let us know. Our email is alwaysonem@gmail.com. We also are on Instagram and a lot less on X or Twitter, but you could potentially message us there. And Alex, anything you want to say about that?
Nope, I agree completely.
And I think today's guest is one of those people. When we talk about trying to arrange the best of the best, the upcoming guest is one of the best, if not the best, educators in medicine. And if you remember from chapter 14, this was January 1st, 2023, starting the new year that year, we had the wonderful educator, Dr. Jim Gregoire, who is a nephrologist for Mayo Clinic. At the time he was here in Rochester. He's since left, Alex.
I hear that he's moved to a warmer location. Dr. Gregoire, where are you now?
I'm the Minnesota kid. I actually love winter. I like to do a winter camping trip every year. But my wife, she moved down to Mayo Jacksonville in Florida a couple of years ago, and 8 months ago I moved down. So the Gregoire force has been restored. The team is back together.
I can't imagine being long distance from my spouse at this stage in our lives. When we're younger, we did it, but power to you.
We're so happy that you all are together, but we here in Rochester are sad that you've left us, and but we're so happy to have your teaching virtually here today.
Absolutely. And, you know, Alex, I teach the medical students about ultrasound when they're in the ED every month. And consistently, they talk about how amazing the nephrology ultrasound experience is. And they talk about you and your legacy, having built that and missing the teaching that you gave to that group. And that's just one group that sings your praises. And there's so many.
Good to hear.
To remind everyone briefly, Dr. Gregoire got a degree in chemistry from Gustavus Adolphus College. Then he joined Mayo Clinic. At Mayo Clinic, he has gone to medical school, graduating in the class of 1986, completed internal medicine residency, nephrology fellowship, and even acquired a master's degree in pharmacology. He is currently serving as a consultant physician, that's attending physician for the United States audience, in the division of nephrology and hypertension. He has so many accolades to his career that I could mention, but I want to point out that he has a page worth of education awards. Among them, I want to point out that he has received an education award from the Army. He's been the recipient several times over of Excellence in Teaching Awards from the medical school. He's been labeled several times over as a top 20% educator by the Internal Medicine Residency. He's been listed as Teacher of the Year by the Mayo Fellows Association. He's received 2 Golden Apple Awards from the medical school, which represents the best instructor for the first and second year students. He's been given a Distinguished Teaching Award by the entire School of Medicine as well. And using all that, he's also been able to serve as Education Chair for the Department of Internal Medicine. Along the way, he has done even more things than I could mention. The take-home point is that he's truly a world-class teacher, and we've seen that or heard that firsthand before, and I'm excited to learn again from him. With that in mind, it's probably time we get started. Alex, go ahead and kick us off.
Well, today we're here to talk about electrolytes. And this is one of those things that I think when I was in medical school, I perceived that it was, these ions floating around, and I was interested in things like a pneumothorax, and I thought it wouldn't impact me. But I'll tell you, Venk, when I reflect on my entire career I think that an electrolyte case actually was the most driving factor in me becoming an emergency physician. I vividly remember my first emergency rotation. The attendings are always scanning patients that they perceive potentially are low risk, and then they send in a medical student, and I take this great history and I'm really thorough, and I come back and the attending expects that things are going well and there's enough time for me to get a history. And so I was sent into this room for a young patient, and I was taking a whole long history with a detailed social history. And all of a sudden, she begins to go unresponsive. And I look up at the monitor, and it doesn't look right. At the point in my training where I was as a third-year medical student, I knew things didn't look right, but I didn't quite know what was going on. And this was a very young patient that had a lot of complications after a pregnancy. And I walked out to go get the attending, and he was already running towards the room, and the monitor tech just yelled out, it's a wide complex tachycardia. I saw it change suddenly. And he walked into the room and asked me, what did you hear? Suddenly the med student history became very important. My detailed history, there was added value. And there had been some renal issues. And he said, we're going all in on treating hyperkalemia right this second. And immediately got ROSC. And we, checked a VBG at that point after empirically treating, and the patient had a very high potassium and then went on to need temporary dialysis and had a great outcome. But I was so struck in that moment by how, this chemistry issue so profoundly caused an emergency and how quickly they were able to treat it. And in that moment, I felt a deep calling in what I wanted to do with my life. And so I am constantly striving to understand more about this. And the deeper I get into it, Dr. Gregoire, I'm left with even more questions. Although I feel like I can navigate hyperkalemia, a lot of other electrolyte issues, I just want to hear how I could be better. And that's the goal of today's discussion, I think. What do you think, Venk?
I absolutely agree. And even just the other day, we had a case where we were really considering why the ECG looked so abnormal, almost very much like a STEMI, but had to divert because we were suspicious the potassium was high, and it turned out to be. And as we corrected it, the ECG returned to normal beautifully, and all the better for the patient, because I think that was easier to fix. But very much.
Hyperkalemia keeps nephrologists in business. Such a lot of it.
Absolutely. And the other things, though, I feel like I see phosphorus values, magnesium, calcium, and I don't remember as much as I should about how to manage that, what's happening to them, when I should be concerned, what are the nuances and replenishing it. And so even though sodium and potassium they're like the leaders of the A team, I think all of them really could use a lot of attention, and I'm hoping that you can help us.
Sounds good. Yeah, not long ago, we had a case. The ECG was horrific, and the potassium came back at greater than 10.
Whew.
They couldn't actually determine the value. All they could say was greater than 10.
Ooh. So we obviously assume it's fake.
Yeah. So the value doesn't get released, and yes.
Let's wait an hour, recheck it. Do you have a favorite electrolyte, Jim?
I see so much hyponatremia.
I like that one too. And Alex is wondering if you and I might disagree a little bit on hyponatremia. Should we jump into that one?
I think we have to jump into hyponatremia.
Yeah, let's do that.
Sure. Yeah, okay, hyponatremia, source of frustration for many physicians. It's one of the main reasons people go to online references like UpToDate, and actually hyponatremia is the number one reason. So we're never completely comfortable with the diagnosis, and we're never completely comfortable with the plan. And we should make a preliminary diagnosis and make a preliminary plan, but then not get locked in with our plan. So we've always kind of got to reassess and readjust and be willing to make an adjustment.
Alex, do you want to kick us off with a case?
Yeah, absolutely. So you have a 6-year-old gentleman who is registered in your ED, and in your triage doc or provider has ordered some labs, and hyponatremia returns, and they felt a little bit weak. There's some mention that at one point they were confused, but they're awake and alert now, and they're just feeling a little bit weak. And their sodium is 120, and their neurologic exam is normal. And you're left with a question of what's going on with this patient? How do I treat it? And more importantly, how aggressively do I treat it? And so, Dr. Gregoire, when you get a consult, because this is the most frequent thing that we're saying people look to up to date on, and they institute a preliminary plan, and then the big guns get called in, meaning you. What's your general approach to the patient, and then we can kind of dig into what I'm interested in, which is how quickly do we correct a sodium?
Yeah, and you mentioned the person probably not having any symptoms, but studies show that most people do have some subtle symptoms when they have hyponatremia. We doctors don't appreciate the symptoms. It's only after the sodium is corrected that we realize, wow, this person was just a little off. Their gait was a little abnormal, and it was subtle, and we didn't appreciate it.
Yeah. Dr. Gregoire, are you insinuating that the ED neuro exam is not is not entirely comprehensive?
He doesn't have to insinuate. I'll go ahead and outright say it. That we could do better.
Okay. All right.
To that end, what are you asking questions-wise to these patients on history? And then are there particular physical exam things that you highlight for your trainees with regards to hyponatremia?
I ask them how their mind is. I ask them, do you feel a little foggy? Okay. See if they have any cognitive changes from the hyponatremia. And I ask them if they have any nausea. I guess those are probably two questions I always ask the patients with hyponatremia. And if they're having those symptoms, then I say, you are having symptoms from hyponatremia. So that makes it a little more intense. If the person's asymptomatic, truly asymptomatic, then I kind of breathe a sigh of relief. But if they're having symptoms, whoa, yikes, might have to do something a little quicker. And let me ask you guys in the audience if you would agree with this statement, that for symptoms from severe hyponatremia, the preferred therapy is hypertonic saline.
I would say yes.
But some cases isotonic saline will work. I'll repeat the question. For severe symptoms from severe hyponatremia, hypertonic saline is the preferred solution, but in some cases isotonic saline will work. And that is true. So whatever the cause for the hyponatremia, if they're having severe symptoms, altered mental status, gait changes, bad nausea, or even worse, seizure, then hypertonic saline is the preferred therapy. And the nice thing about it is using hypertonic saline has gotten so much easier. All those decades or maybe centuries ago when I was a resident, if we ever gave hypertonic saline, we would get real nervous and start to sweat because we would have to do some elaborate calculations and start an infusion. And we'd have to estimate water excess, sodium deficit, and start an infusion. But now we know, we can just give mini boluses of hypertonic saline, 50 milliliters of hypertonic saline, see how the person responds, or 100 milliliters of hypertonic saline, see how the person responds. So it's made the treatment of symptoms from hypertonic saline so much easier. And believe it or not, a lot of that experience came from first providers working in the marathon tents. So people after marathons, they feel wiped out. And people realize some of those cases were from hyponatremia. So that the first responders in the marathon tent would give a mini bolus of hypertonic saline and it worked. So that got translated over to hospital care, and lo and behold, the mini boluses work and are nice.
Jim, I'd like to dig a little further on that. You talked about severe symptoms, and you mentioned even things like nausea, which I think to most emergency physicians does not stand out as a severe symptom. And the other thing is there used to be such emphasis on whether this was acute hyponatremia or chronic hyponatremia. And does that factor in when a patient is having severe symptoms and has a severe level of hyponatremia in your decision to do hypertonic?
Yeah, definitely. And the funny thing about the definition of acute versus chronic is 48 hours. If the hyponatremia has been present for more than 48 hours, we say it's chronic. And
so the thing about that is some of our patients wait in the waiting room 48 hours. I'm joking, but
I do think this actually gets to something, that I struggle with this issue. Venk, you brought up exactly what I'm thinking. Nausea, what nausea are we saying this is a severe symptom? And additionally, like what you said, Dr. Gregoire, initially, you ask, at some point, are you a little fuzzy from time to time, but you're awake, alert, and oriented? That is different than I'm altered and having a seizure. And that line, deciding where severe is hard for me at times. And similarly with acute and chronic, our patients usually don't have labs in the last 48 hours. And so really, I'm just saying, when did your symptoms start? But I have no idea how long this has been going on. Maybe 2 months ago, they got a CBC and a BMP at their PCP's office, and it was, 130, and then today it's 120. I have no idea. 48 hours. How do you approach that?
I hear what you're saying. Yeah, if we don't have any data, it's hard to know if it's acute or chronic. So I guess we would have to go by symptoms, and if they're telling you, wow, doc, 3 days ago, I just started feeling crummy, and then I'd suspect that maybe it is chronic hyponatremia. And I also hear what you're saying about nausea in the emergency department, really common symptoms, so it's hard to know, is it mild or is it severe? I agree. So we got to kind of put the whole picture together. And if they're looking kind of ill, then it's time to do something about it. And even if the hyponatremia is chronic and they're having symptoms that are making you nervous, then we can treat that. And that's the nice thing about the mini boluses. We'll just see a minor rise in the serum sodium. So the way I look at it is, if we can just get the sodium to stop falling, if we can put a brake on the sodium so it stops falling and just get it to level off or just come up a little, then the patient will usually start to feel better and do okay.
I think that's so insightful. And so we're saying give a 50 ml or 100 ml bolus of hypertonics with 3% saline, and we're just doing small tests to see what improves. I think a lot of times we're afraid of causing harm. And can you speak to kind of how much you would, tell your trainees is deleterious in 24 hours? Do those old rules apply? And what is it that you're worried about when you see the sodium rising?
Mm-hmm. Right. And we hate to see the sodium rise too fast. And often in the emergency department, for your patients, you're giving isotonic saline, right? Because so many of the patients in the emergency department, their volume contracted. So you guys give a liter of isotonic saline, usually works for most cases. So, and I'm talking about when would we use these mini boluses? I guess again, if somebody's having symptoms. So,
I tend to teach our residents about the JAMA article, Systematic Review on Managing Severe Hyponatremia. It really didn't make much distinction on acute versus chronic. It really talked about the sodium level under 120, even without symptoms, treating aggressively, under 125 with symptoms, treat aggressively as having better outcomes. Are you familiar with that paper?
Right. We define severe hyponatremia as less than 120. because when it's less than 120, much more likely to have consequences.
This is Venk cutting in. I had just mentioned a JAMA Internal Medicine article, and just so that we're all on the same page, I'm talking about a publication by the lead author, Juan Carlos Ayus. Hopefully I'm saying that properly, and is titled Correction Rates and Clinical Outcomes in Hospitalized Adults with Severe Hyponatremia, a Systematic Review and Meta-Analysis. And this was published in 2024 in JAMA. And basically, it's a systematic review and meta-analysis with really high-quality methodology, as you might expect. And they looked at patients who had severe hyponatremia, being under 120, and those who had moderate hyponatremia, which was under 125, but had symptoms. And they didn't really stratify by acute or chronic, and then tried to see what were the outcomes based on the correction rate, whether there was an aggressive correction strategy involving hypertonic saline or a more prolonged correction strategy using isotonic fluids, and then reassessment. And it's a wonderful paper, great methodology. I highly recommend you take a look at it to make sure that you believe in the outcomes. To me, it felt like something that would change my practice. And in summary, it found that there was a increased risk of mortality, and hospital length of stay was also increased when patients had slower correction rather than rapid correction. And it just adds more evidence to say that in general, even though we worry about central pontomyelinolysis and other consequences, those are very infrequent. And this is something that we can make an impact to a large number of patients by correcting a little bit faster.
So for our learners who are approaching this for the first time, is there an amount over the course of the day where, we give some saline and then they got one or two hypertonic boluses where you start to say this was too much, and then how do you get out of that if you're boarding a patient in the ED for a long time?
Yeah, if you've had to give 3 boluses and things aren't working out, patient's not so stable, I'd say, wow, you did the right thing. It's just the patient was too complex, and we better start looking at a different plan.
Sounds good.
If ever you guys in the emergency department could get a urinalysis, all of the nephrologists in the world would bow down and give thanks. Okay. So, so we really like those urinalyses before treatment has been started. And I realize when the person's in the ED, they might not feel like urinating. So I understand why a urine specimen's not obtained. But what often happens is some therapy is done in the emergency department, and then they come up to the hospital floor, and then we get the urine osmolality and urine sodium. They're not as easy to interpret. So if you can ever get a urine osmolality and urine sodium just prior to treatment, that would be awesome, but I realize it's hard to do.
While we're on the subject, is it still a thing that if they're on certain diuretics that we need a urine urea and urine creatinine as well?
Guess what? I and others find that the urine urea is very unreliable.
Okay.
I basically never order it.
So if you were ideally asking us for orders, it's a urinalysis, urine osmolality, urine sodium.
Yep, and for hyponatremia, we wouldn't really even need a urinalysis, just a urine osmolality and a urine sodium.
Awesome.
Okay. Yep.
And do you need it at a certain time in relation to serum osmolality and serum sodium?
Within several hours, it's probably fine.
Got it. And
I'll describe a case that we occasionally see that's kind of cool. So someone comes into the emergency department and they've got hyponatremia, and the emergency department doctors go ahead and they get a urine osmolality and urine sodium when the patient arrives. And wonders never cease. The urine osmolality is very low. The urine osmolality is very low. And what does that tell us? Well, that tells us it's not an ADH-mediated process. It's not a appropriate ADH like we would see with volume contracted. It's not an inappropriate ADH. ADH is not playing a role in this case. And what's going on? Why would this person have hyponatremia with dilute urine? And then the third-year medical student goes back into the room and asks the patient a little more information. And the student says, "Sir, what do you have for breakfast?" "Well, I have maybe an egg and a beer." "And then what do you have for lunch?" "I might have a sandwich and a couple beers." "And then what do you have for dinner?" "I might have another small sandwich and a few beers." So there's a guy who's got beer potomania, and we pick that up because we find the urine osmolality is very low. So beer is an electrolyte-free solution. It's carbohydrates and water. And a person who's drinking a lot of beer, of course, they're drinking large volumes of liquids. And again, it's electrolyte-free, and it just overwhelms their kidneys, and they get hyponatremic from that. And all that extra water goes out into the urine and makes osmolality very low. So it's something I'm always surprised when we see these cases that are not ADH driven. It's not a rare thing. So if we see someone with hyponatremia and low urine osmolality, we should say, this is not ADH driven. This is different. This is unique. And it could be beer potomania. And it's always funny how often I'll get a history like that person's consuming beer all day long. Another cause for hyponatremia with low urine osmolality is someone who's got the tea and toast syndrome. Okay, failing to thrive. They're just not taking any minerals in their diet. And if we don't take in much protein or minerals, then there's not much urea passing through the kidneys, and the person can't excrete water. And we'll see that up on the hospital ward. So we'll see someone who's been in the hospital for a few weeks, recovering from osteomyelitis or something, and we see them and they've got hyponatremia, and people start to think, oh, it must be SIDH or something, and lo and behold, the resident gets a urine osmolality and it's low, and that tells us, it's not an ADH-driven process. Why would osmolality be low? And again, it's the person's just not eating and drinking much. So I kind of like those cases because the treatment I prescribe is drink less, eat more.
I wish somebody would tell me.
Yeah, I think I'd appreciate that. I'll take that prescription anytime.
Yeah.
Less, eat more.
While we're on the topic of differentials as potential cause for hyponatremia, are there certain medications or classes of medications that we should be focusing our history on, other activities that we should be making sure to take a history on when we're trying to discover why somebody's hyponatremic?
Yeah, so guess what? At the world famous Mayo Clinic, when good old Epic first came along, one of our colleagues got so stressed that he started taking a SSRI, and it caused his sodium to drop, and he got a seizure. Okay, wow. So SSRIs are one of the big ones I ask about, and of course some seizure medications can cause hyponatremia, and then thiazide diuretics would be the other one. So those would probably be the big two, would be SSRIs and thiazide diuretics. Other antidepressants like SNRIs, a little less likely to cause hyponatremia.
Also, with patient history and factors, how much influence does heart failure, liver disease, end-stage renal disease, or different forms of kidney disease play in our evaluation and management of hyponatremia? Should they weigh in at all in how we manage this?
Oh, yeah, no question about it. So that's probably the most common cause for hyponatremia in the hospital. So in those cases, we would see increased urine osmolality because there is ADH. So those people have low effective circulatory volume. So someone with heart failure, low effective circulatory volume, cirrhosis, low effective circulatory volume, nephrotic syndrome, low effective circulatory volume. Their baroreceptors are underperfused, and therefore ADH is being secreted to try to improve the effective circulatory volume. But unfortunately, too much ADH leads to hyponatremia. So that's a really common reason for hyponatremia in the hospital, heart failure and cirrhosis. And in those cases, we'll see hyponatremia, we'll see low serum osmolality, we'll see increased urine osmolality, And in those cases, the urine sodium will tend to be low because the RAS system is activated and the kidneys are really hanging on the sodium. So it's high urine osmolality and low urine sodium. So we see that all the time. And the treatment for those patients is easy for the nephrologist to prescribe, but hard to accomplish sometimes. The treatment is try to improve the effective circulatory volume, but it can be hard with someone with bad heart failure or bad cirrhosis. So for heart failure, we'll try to actually give them a loop diuretic to help their congestion. Hopefully with improved heart function, then they're able to excrete extra water.
This is so helpful. And so to kind of run it back and make sure I have an approach as a first line and trying to get the Dr. Gregoire stamp of approval for my first line ED approach. If I see hyponatremia, I'm breaking it into mild, moderate, or severe. And there's different ranges, but potentially 125 to 134, roughly mild, 120 to 124, moderate, and then severe, less than 120. And really, I'm trying to look for symptoms, and they can be mild symptoms, or they can be things that I otherwise attribute to being mild, like nausea or episodes of altered mental status, but I'm really hunting for those to identify if hypertonic saline and small boluses could be effective at making the patient better. And
I think that's a good point, because about the mild symptoms. In our world, so many patients are obtunded, altered, nauseated, puking, that these symptoms for hyponatremia that are signs of severe hyponatremia or something significant are relatively mild compared to most emergency department patients. And so that puts us at a disadvantage to recognize it and appropriately treat them.
I totally agree. And
good job.
And so when I'm looking at hyponatremia as a disease entity, the way, when we're reviewing it as a general approach, I'm checking a serum osmolality, and I'm breaking it down into high, normal, or low. And high is kind of classic picture of hyperglycemia or some other hyperglycemia type things, like the patient got mannitol. Normal osms, maybe there's high protein or hyperlipidemia, but the most common thing we see is low osms, and that's where we try and do a volume assessment. And we have the hypervolemic patient that you just described with heart failure, and although there's too much fluid, they don't have enough sodium. There's the hypovolemic patients that we see a lot in the ED, and that almost feels a little bit easier because we can give saline and then try and calculate and get the urine sodium. And then there's a euvolemic group where SIADH leads the pack, and there's some other causes. I think when I step back and look at this, SIADH is pretty common. It is easier for me to prescribe a bag of fluids than to articulate a fluid restriction and what that means to a patient. And when you're saying you have SIADH, we want, and you have mild to moderate hyponatremia, how do you describe to a patient, I'd like you to cut back on your fluids? What language do you use so that they understand what that means?
Yep. So we have to prescribe a certain volume of fluid every day. Might be 1.5 liters every day. And that's really hard to accomplish in the hospital. I always cringe when I walk into the patient's room, patients on fluid restriction, and there on the tray, there's a glass of orange juice, can of Sprite, and a couple glasses of water. So it's hard to accomplish. And the patients, they're surprised. They say, gee, doc, I thought drinking plenty of liquids is a good thing. And for most patients it is, but for someone with SIADH, they got to try to learn to reduce their fluid intake.
Alex was kind of talking, and he mentioned the word calculate, and then he took it back. But I'm curious, should we be doing the fractional excretion of sodium anymore? Is that something you're still doing?
So people use the fractional excretion of sodium to kind of assess what's the cause for the acute kidney injury. guess what? I don't really request it anymore. Okay, history wins out. But just the plain urine sodium can kind of help us with assessing and managing hyponatremia.
The other calculation that I'm curious about is correcting for glucose. I still do that, but a lot of times I'm faced with, there's two different calculation options. One with a 0.016 factor and one with a 0.024. Can you guide me? Is one better than the other? I don't know when to use one or the other.
I went out and go kind of halfway, but that's a good thing you're doing, Venk, because yes, a really common cause for hyponatremia is hyperglycemia, and I'll miss that patient. Doctors will call me and say, I got a patient with hyponatremia, and I'll forget to ask what's the blood glucose. So that definitely will cause hyponatremia. So all that sugar in the blood will draw water out of the cells and dilute the sodium concentration.
I think the last thing that I think about with these patients is how do I, not run into issues. And when I was a resident, we would say, okay, you don't want to go increase by more than 8 the sodium over the course of the day because you'll cause central pontine myelinolysis. And over the course of my career, we've been now giving more hypertonic saline. We're becoming more aggressive. Is that 8 still something that that you try to adhere to? How do you look at those numbers when we're drawing a sodium every 2 hours in the first day of the hospitalization?
Mm-hmm. Yeah, we're nowadays we're kind of shooting for a number of 6. But let me just say that hyponatremia, it's an area that physicians can say, wow, this is a medical success story. Okay, because when I ask residents, have any of you seen a case of osmotic demyelination? They look around at each other and they say, no, I've never seen that. Meanwhile, an old guy like me, I've probably seen 3 cases in my career. And so we've learned so much about hyponatremia, the causes, and we've learned so much about the management. And interestingly, retrospective trials, they'll show that, wow, they'll see the sodium go up in patients and they say, oh, this person should have got osmotic demyelination, and lo and behold, they didn't. So even in cases where you expect the person to get osmotic demyelination, it just doesn't happen. So I consider treating and evaluating hyponatremia really an area of success. The last case I saw of osmotic demyelination, an older fellow, he was hospitalized at home for severe congestive heart failure, and the doctor said, wow, you better start on 2 diuretics. And the 2 diuretics worked really well, and he was dismissed. And a week later, he came back, and he couldn't walk or talk. And lo and behold, he had severe hyponatremia from the 2 diuretics. And so they said, well, let's stop the diuretics, and sent him on his way. And then he came back because his serum sodium had risen so much that now he had osmotic demyelination with changes in his brain. And he was transferred to our hospital. And I looked at the scan and I looked at the patient, and I stepped out of the room to talk to the family. And I said, boy, this just isn't going to go so well. And I was completely wrong. This older fellow, he healed just fine. So even cases where osmotic demyelination occurs, it's not a death sentence. So patients can improve, which happened in his case.
That's really helpful. So it feels like very much like other things we do, like vent management and fluid resuscitation. If we have a suspicion that the patient is hyponatremic and potentially having symptoms from that, and we're on the fence, it's probably safe to give a small amount of hypertonic and reassess how they did and what it did to the values without feeling too much fear or anxiety that we're going to cause a devastating neurologic disaster.
You got it. And of course, in the emergency department, a lot of cases of hyponatremia you see are from volume contraction. So you're routinely giving, a liter of isotonic saline. and the patient does just fine.
Yeah. Can we switch gears and talk about hypernatremia?
Let's do it.
I feel like I don't have even that rudimentary knowledge that I have with hyponatremia. I don't have that with hypernatremia. Can you walk me through what are the history and physical exam findings of hypernatremia that I should be on the lookout for? What things should I be thinking my differential and how to approach that?
Yeah, so hypernatremia we're almost always successful with, okay? And there's only just a limited number of case reports of someone having consequences from the treatment of hypernatremia. Okay, and, we're always really cautious about treating hyponatremia, but guess what? People tolerate the treatment for hypernatremia very, very well. And an interesting thing is if you took a group of patients with hyponatremia and you took a group of patients with hypernatremia and you compared their long-term outcomes, lo and behold, those with hypernatremia would have the worst outcomes. And why is that? And it's because hypernatremia tends to occur at the extreme of ages, so really young infants or really old people who've got a lot of comorbidities. So it's kind of a bad marker. And hypernatremia is almost always due to a water deficit. Mistake people think, they got too much sodium. It's not enough water. So they've lost water from diarrhea or sweating or increased respiratory rate. And if you and I, we had the pleasure of having diarrhea together, okay, we wouldn't get hypernatremia, okay, because thirst is an incredible urge. It's one of the strongest urges in the body. And as soon as our serum osmolality and sodium start to rise, then our osmostats in our hypothalamus, they'd sense that hypernatremia, and they'd be secreting ADH, and they'd be stimulating our thirst, and we'd drink water, and we'd be fine. So it'd be unusual for a healthier person to get hypernatremia from fluid loss. But I think someday I'll end up in a skilled nursing facility, and there they might have me on some fluid restriction, and maybe I have some immobility and I can't get up to get water like I need. And maybe I'm old and I just can't sense thirst very well. Those are the patients that get hypernatremic. And the sodium can really shoot up fast, wow, all of a sudden 155, 160, and they get altered mental status. So they'll get very altered, confused, and, have symptoms very similar to hyponatremia. And they'll come into the emergency department, and guess what? They're going to do fine. So we just have to replace their water. And if we see them and their effective circulatory volume is low, let's say they've had so much diarrhea that they've lost a lot of fluid and they've lost a little more water than salt, so they're hypernatremic. So they got hypernatremia, really low effective circulatory volume. What should be the first replacement fluid? And you might be tempted to say, they got hypernatremia. I ought to give hypotonic fluids. But no, if the effective circulatory volume is low, that wins out. And we should give isotonic saline in a case like that to restore their effective circulatory volume. And once their effective circulatory volume is restored, probably the hypernatremia will start to correct on its own. But once you've got the effective circulatory volume and the hypernatremia persists, then you could switch over to hypotonic fluids. You could switch over to half normal saline. You could switch over to D5W. And you can do some calculations to calculate the free water deficit, which are helpful. And I'm always surprised when we do those calculations how much water deficit is. And like I said earlier, though, we just have to pour in the wah-wah, and eventually things improve.
So a couple questions. So if I'm hearing correctly, we should do what we are very good at, which is giving normal saline to these patients.
Got it.
And then you talked about calculating free water deficit. I haven't done that in a long time, a very long time. I don't know where to begin. Can you walk me through how to do that?
That's the serum sodium divided by 140 minus 1, that quantity, okay, serum sodium divided by 140 minus 1, that quantity times the ideal body weight. And that'll allow you to calculate the water deficit. And you can use that then as a guide to how much fluid to give. So again, if a person's shocky, give isotoxin. On the other hand, if they're stable, their blood pressure is fine, they've just got hypernatremia, then you could start with some hypotonic fluids. And do we ever need to do any testing to sort out the cause for the hypernatremia? Not usually. Again, most of the time it's water deficit. They've had too much diarrhea. They've had too much vomiting. They've lost fluids. They've had some diuresis or something. We usually know the cause. But once in a while, one test can give you some help. And that, in case of hypernatremia, is to check their urine osmolality. Okay? And what would be the diagnosis if we saw someone comes into the hospital and they have hypernatremia, and you say, easy, water loss, must have been from diarrhea or something, and the second-year medical student checks the urine osmolality, and it's very, very low. You say, wait a minute, that doesn't make sense. The kidney should be concentrating the urine, trying to hang on to water, but here's a case where the urine is very dilute. What's the diagnosis in that case? And that is a case of diabetes insipidus. And so that's really about it for the differential. The differential is water loss, water loss, water loss, water loss, water loss, water loss. And once in a while, lo and behold, it's diabetes insipidus. And the most common reason we see diabetes insipidus in the hospital is good old lithium.
What a great review. It's been a long time since I thought about any of that.
I completely agree. And I really like the simplified approach you've given to us and our listeners. And, we have a patient who has a history of SIDH, went to their skilled nursing facility, has had an acute illness a little bit, and basically shows up with a degree of altered mental status, which is something we see. This isn't a code, this isn't a stroke activation, but just they seem off from their baseline. And we check the sodium, it's 155, and they look dry. We can give them a liter of saline, even though there's sodium in it, because it's lower than where they are. So it's still going to dilute things out. And now we've got this value back, and it's 155. And for the ED docs, but not the nephrologist, will for a moment be like, I just gave more saline. But then we're going to pause and we're going to think that actually we did a good thing and we increased the circulatory volume. And I think where I would struggle with this is there are MD Calc and calculators for a free water deficit. And, if I see a 2 liter free water deficit, what does that mean to me in the ED? In the same way, CPS, what do I have a goal for per hour? Like, can I correct this in 5 minutes? What am I shooting for here?
I don't have a suggested rate, but all I can tell you is that patients will tolerate it just fine. Okay. Yeah. So I'll typically ask the team to give maybe a liter of D5W over the next few hours.
Perfect.
And then reassess.
That is awesome. And then I'm usually admitting the patient, and they're checking every few hours. And this is great. I have such a better understanding of this because of our conversation.
That gets to a good point. In both cases, hyponatremia and hypernatremia, which patients can we stabilize and send back to their nursing home or home and have outpatient follow-up, and which patients need to be admitted?
I'd say either one. Just depends on their circumstances and how they look.
Okay. So there's some judgment involved there.
Yeah. Hopefully you can break the underlying cause, or it'll happen all over again.
Right. Absolutely.
We wouldn't want to take it away an outpatient nephrology referral, though, so we don't want to overstep. We don't want to fix it too well.
Gotcha.
Well, that was your favorite electrolyte. Do you have a second favorite?
Let's mention magnesium.
Ooh, I like this one.
Let's do it.
Yeah. Okay, the magnesium, I call it the kidney electrolyte. Okay, why is that? Okay, I'll ask the audience, please name the hormone that regulates serum magnesium concentration.
You know, I wouldn't want to take this learning point away from you, Dr. Gregoire, and so even though I know the answer, I'm going to let you take this one away.
I'll fully admit to my stupidity. I don't know the hormone.
And the answer is there isn't one. Okay. Yeah.
Got to stand
tricky,
proud and stupid. That's the way.
Yeah.
I see it.
Strong and wrong.
Yes.
That's funny. For sodium, we've got ADH, and for potassium, we've got aldo. But for magnesium, there is no hormone that regulates its concentration. So some people call it the orphan electrolyte. It's kind of on its own. And I like to call it the kidney electrolyte because whatever the kidneys are doing kind of determines the magnesium concentration.
Probably the full extent of my magnesium education was in the ICU, my senior saying, get the potassiums above 4 and the magnesiums above 2, and I don't need questions about anything beyond that. And, and so as an intern, I would just check those, make sure we were good and replete liberally.
Well, see, what you were saying really resonated with me, Jim, because I've always felt like whatever the potassium is doing, generally the magnesium is going to do the same. If I'm giving potassium, I should give magnesium, that kind of thing.
Yep, you guys are right. But interestingly, studies from the ICU show hypomagnesemia is really, really common now. And, might be as often as 20% or so. And it's a problem because hypomagnesemia, well, if we have that, then the person's prone to cardiac arrhythmias and things. So I'll give you a case and you tell me what happens. So person comes into the emergency department with an acute myocardial infarction and the magnesium is a little bit low, and the doctors know, wow, we don't want hypomagnesemia in the setting of an MI because we could get fatal ventricular tachycardia. So some magnesium is given, parenteral magnesium, and patient survives and does well. But then you go back and visit with him a couple hours, and he says, gee, doc, I can't move my arms or legs very well. My arms and legs are weak. Yeah. And
I would say that we were overly generous, and this is feeling a little bit like a patient with preeclampsia, and they're on an infusion, and we're supposed to be checking reflexes. Is that what's going on?
Good job. Yeah, so this person I described got hypermagnesemia. And why did that happen? Lo and behold, the person has advanced kidney disease. So when we replace the magnesium, we should ask ourselves, how's the kidney function? Because the one patient you'll see where giving magnesium could lead to hypermagnesemia, someone with low kidney function. And if the magnesium gets high, then they get muscle weakness and lots of reflexes.
That is so helpful. Is there a predicted response? When I give potassium, I don't know if this is right or wrong, but 10 milliequivalents of potassium, I usually say is about 0.1 of roughly what I'm going to expect. Maybe that's a lie. I tell myself to sleep better at night. Sodium, I don't really have a great reference. If I'm giving the hypertonic, I'm just saying I want the symptoms to get a little bit better, and hopefully I'm not going to go over 6 for the day. For mag, usually I give a gram or 2, and I'm just kind of shooting for an improvement. But is there some kind of response, or with a patient with end-stage renal disease, is there a window that you typically give to replete a low mag that feels safer?
And you could say There's no real safe replacement. Got to be really cautious with someone with end-stage kidney disease. So, yeah.
So if it is low and there's concern for an arrhythmia, I would just replete very judiciously compared to my other patients where I usually feel like a gram or two of mag is not a big deal. And that's kind of similar, I think, to me. A learning point that you gave me in our first podcast was if I see a low calcium in an end-stage renal disease patient, I should resist the urge to make the numbers look good. And is that right too?
That is correct. Now, I must say, most end-stage kidney patients who get magnesium, guess what? They tolerate it fine.
Okay.
We just have to be careful about it. So our end-stage kidney patients, we have to watch out that they're not taking in extra magnesium, like magnesium-containing antacids or magnesium-containing enemas or the like.
Okay.
So
go ahead.
Sorry, just to review, hypomagnesemia, we should be thinking arrhythmias. Any other history or physical exam abnormalities that we might pick up on with that?
With hypomagnesemia, no.
Okay.
It's going to be cardiac arrhythmias.
And then hypermagnesemia, we're thinking initially loss of reflexes and then eventually weakness, especially in the limbs, and then eventually it's central weakness. And then respiratory depression at the very end of that?
You got it.
Okay.
Yeah.
And I know when I was on OB, they really emphasized that the safe window of magnesium is, 10, 15 grams of mag in their population. But you're talking about in renal disease patients, we have to be more cautious. Do you have a sense of what us and our listeners can be thinking? Is it like 2 versus 2.5 grams? That's how close the window is? Or are we thinking if we give 1 to 2 grams, we're going to be still well safe on these patients?
Yeah, you'll be safe.
Okay.
You'll be safe 1 to 2 grams. You just have to, watch it and monitor it. And hypomagnesemia is a problem that we see in the hospital a lot. And there's a lot of known causes of hypomagnesemia. And we can see that in people taking PPIs. We can see that with people taking diuretics. And we can see that people with chronic diarrhea. And we know some of the more common causes, and we're usually able to figure out the cause. This is a situation where some doctors might like to check the fractional excretion of magnesium. But again, I'll say usually the history is going to win out. And I find those fractional excretion numbers kind of unreliable. So history will usually point you to the cause. And then we start some treatment, which usually is get rid of the PPI, get rid of the diuretic if we can, and then start some magnesium replacement. But as I say that, I'm sitting here shuddering, Venk, and feeling very nervous and sweaty because replacing magnesium is difficult. Okay? It's a funny thing. So it's one of the bane of a nephrologist's existence is someone with chronic hyponatremia, because if once we start giving oral magnesium, guess what? They get diarrhea and then more magnesium.
Right.
Okay. Yeah. And then, so there's some people that have chronic hyponatremia. And so then we're tempted, well, let's give the person some intravenous magnesium. And guess what? Once we give that intravenous magnesium, all that magnesium goes to the kidneys and out it goes in the urine. So it's really hard to replace. So there's some forms of oral magnesium that are maybe a little more effective. So maybe mag-ox is more likely to cause diarrhea. So there's other forms like magnesium lactate that might be a little bit better tolerated. And what's most effective for me is to encourage the patients to eat foods that are rich in magnesium. So I encourage them to eat plenty of green, leafy vegetables, legumes, nuts, dairy products. How do you like that kind of a menu? Green leafy vegetables, legumes, nuts, and dairy products.
It seems like a good salad in the making.
It sounds delicious. And yet again, I'm faced with a situation where I thought I was fixing something easily and I'm not. So the 2 grams of mag I gave to facilitate a safe disposition was probably not the panacea that we thought.
And we'll see hypomagnesemia from various causes. So I mentioned a few. Sometimes it's medication, like a PPI or a diuretic. But we'll see some patients that have chronic hypomagnesemia for years. And how did that come about? Well, sometimes it's from chemotherapy years ago. So there's certain chemotherapeutics like cisplatin that are poisonous to the renal tubule, and then the person is stuck with hyponatremia forever and a day. Yeah. And then there are a few people that have some inherited disorders of the renal tubule, like Gittleman syndrome, Bartter syndrome, and they're also always prone to hypomagnesemia. And for those patients, we try to encourage them to eat plenty of green leafy vegetables, beans, legumes, and dairy products. And we give them some oral magnesium as they can tolerate. But there are some additional medications we can give for people with chronic hyponatremia. So lo and behold, potassium-sparing diuretics like a Miloride can help correct chronic hyponatremia. And
Jim, just to cut in, I apologize. You've said hyponatremia a couple times. Do you mean hypomagnesemia?
Yeah, hypomagnesemia.
Okay. Got it. Perfect.
Yep. So and there's another newer drug that we use for hypomagnesemia, and we in nephrology love these wonder drugs. SGLT2 inhibitor has been shown to be helpful for hypomagnesemia. Mm-hmm.
Interesting.
That drug seems to be just saving the world.
It's everywhere.
Yeah, so this is a new era for nephrology, Venk.
I love it.
So for years, we haven't had a lot of great treatments for some kidney conditions. Now we're quite excited. We're really excited about the SGLT2 inhibitors, and we're really excited about the GL1 PRAs for people with chronic kidney disease. And it's amazing. When people get started on those drugs, we see an improvement in mortality in just 3 years.
That's beautiful. Wow.
Yeah.
The serum mag level, how accurate is that of the total body magnesium? And is it something we should be focused on if the symptoms don't match?
Good question. Yeah. So the serum magnesium, that's just a tiny, tiny fraction of total magnesium body. So you're right, Venk. If the person's having symptoms or signs you think might be from magnesium problems, the serum magnesium level might not be telling the whole story.
Perfect.
Moving on to, in our last few minutes, questions from the depths of my incompetence, phosphorus. So when I see a phosphorus added onto the labs, I immediately think I have kind of a general feeling of what phosphorus is. Like,
I just think the nephrologist can handle that.
They're like something with energy, like, okay, this will explain their feeling weak. I don't have a great grip on it, and then also repletion. Like, I feel really good about potassium repletion, mag, but phosphorus, suddenly there's like packets of things going into the room. Can you explain a little bit about phosphorus, what we should be which types of patients we should really be getting a phosphorus on, and how we can confidently approach that?
Mm-hmm. Yeah, so for hypophosphatemia, that can definitely cause symptoms. And, normal phosphorus level is down to 2.5. Levels less than 1.5 or less than 1.0 can definitely cause symptoms. We need phosphorus to make ATP. So hypophosphatemia is prone to causing weakness. And if the phosphorus gets really low, then the red blood cells can't function. Their membranes fall apart, and you can get severe anemia from hypophosphatemia. So
that doesn't sound good. I don't like the membranes falling apart.
Yeah, so when should we think about hypophosphatemia? Well, a big reason would be diarrhea. So if we see someone's got some bad diarrhea, feeling weak, then we should think about checking a phosphorus level. Or someone that's just got signs of malnutrition in general, we should think about checking a phosphorus level. And usually that can be replaced with diet, so dairy products and grains and good old Coca-Cola.
There it is.
Yeah.
I'm going to I prescribe Coke and feel confident on my shift. I like this.
Are you a Coke dealer?
Yep. But you can give the K-phos, sodium, potassium, phosphorus. You can give that orally. It comes as a packet or intravenously. And if levels above 1.5, it's probably not emergency. So, I mean, I would say it wouldn't be necessarily something you absolutely have to address in the emergency department. Could be addressed as a, inpatient or an outpatient. And then on the other end of the spectrum is hyperphosphatemia. And that's uncommon unless the person has kidney disease. So the kidneys are normally excreting phosphorus maximally, and if the kidney function goes down, then we're prone to getting hyperphosphatemia. And you guys will see cases of CKD in the ED, and the phosphorus will be quite high, probably levels less than 10 or even less than 15 are not dangerous, and probably don't need to really do anything about it. But for extreme levels of phosphorus, like someone that's got tumor lysis syndrome, then we have to rev up the dialysis machine. So if it's chronic kidney disease and hyperphosphatemia, we do low phosphorus diet and phosphorus binder. If it's hyperphosphatemia acute from some process like tumor lysis syndrome, then we try to do a forced diuresis, and that usually works, but once in a while we have to do dialysis.
Is that something that we would be activating out of the emergency department in those situations, or is it something after a period of a day or so of trying of diuretics then?
Yeah, I'd say you're probably within a few hours after starting your fluids and your loop diuretic, you're going to improve the phosphorus. And if it's getting better, then you can just keep going with the same therapy, and probably the person will be fine.
So there's a chance then, especially as we're boarding patients a lot more, that those few hours might happen under our watch, and we should be thinking to potentially involve nephrology if it's not working.
Mm-hmm.
Got it.
You got it.
Okay.
So the spectrum of things that I do that I think are helping but are actually hurting, calcium is one that if I see it's low in an end-stage renal disease patient, I really won't, unless I thought it was so profound that it's causing symptoms, I would not give calcium. Does that sound right?
That is correct, because the hypocalcemia is usually not causing symptoms or consequences, just the manifestation of the poor kidney function. They got low vitamin D levels. And we know that if we give too much calcium, it just goes in the body and goes in the soft tissues, deposits on their vessels and heart valves.
And then magnesium is a second one that with my end-stage renal disease patients, especially if I'm thinking about cardiac stuff, it's probably okay to give a gram or two, but I'm going to be really thoughtful about, saying, let's tune this up outpatient and you'll be seen in a couple months. You're going to get some mag repletion. That's not what I'm going to do for an end-stage renal disease patient.
There you go. So when you're replacing magnesium, make sure the kidney function is reasonable. Otherwise, you might see hypermagnesemia.
And then phos falls into that same bucket where when I'm seeing my altered patient who hasn't been eating and drinking, I'm looking for a phos really to try and get to the bottom of are they having muscle weakness and membrane breakdown from profound hypophosphatemia. But for my end-stage renal disease patients, I'm not going to make, assuming I don't see profound hypophosphatemia, I'm not making a huge change to try and get it very high, because they're going to have trouble excreting it. And so that'll be something that I look for an emergency low situation or an emergency high situation for tumor lysis syndrome. But outside of those, I'm leaving a lot of slower correction to to teams caring for them in the long run. Does that sound right?
To smarter people.
Yeah, to smart. Yep. Yep. Words are hard.
Right. So the ESKD patients, who have hyperphosphatemia, probably nothing that the emergency department needs to do other than make sure the patient gets to their next dialysis session.
I'm going deep into my hippocampus here, Jim, and I feel like there was a cautionary tale about managing phosphorus without an eye on the calcium. Am I misremembering that?
No. So phosphorus will bind calcium, no question about it. It can lower the ionized calcium. You're right.
And so clinically, do I need a calcium level before addressing phosphorus? Do I need any hormone levels and things before addressing any of these electrolytes? I feel like there was some nuance in some of these, but
Yeah. Well, again, the history will probably give the answer. But if we see hyperphosphatemia, we don't have a good cause, we would check parathyroid hormone.
Okay.
Make sure they don't have parathyroid deficiency. And we would check calcium levels also.
Got it. So in a patient with diarrhea, thus far I have not been checking calcium and phos, but you're saying probably it's wise. These are high risk or patients at risk for hypophosphatemia. And so I could consider replenishing it for them. But before doing that, I should have a calcium level and make sure that that's addressed as well.
I guess in most cases of diarrhea you see in the emergency department haven't been going on that long, and they probably don't have severe hypophosphatemia. But if you ever see a patient like, let's say, has chronic inflammatory bowel disease, so they've got chronic diarrhea, and now they've had an exacerbation of their diarrhea, there's someone who could have hypophosphatemia.
And what happens if we replenish it without thinking about calcium at all?
You'd probably be fine because there's other factors that are regulating the calcium level too. So, if you gave a lot of phosphorus, it might transiently drop the ionized calcium level. But then guess what? Good old parathyroid hormone will kick in and raise the calcium level.
I love that there's so many safety nets for all these things so that we don't cause any harm to anyone. And let's take a minute and summarize our journey this afternoon. We started by talking about hyponatremia. Hyponatremia is essentially the most common reason people are seeking a reference text, especially clinically. And we started by talking about a case of an older gentleman who was coming in with weakness and transient confusion. And the key points are that the symptoms are very subtle that we need to watch out for. Does the patient feel foggy? Do they have nausea? Things that may be even difficult for the patient or family to perceive because they've gradually come on. Sometimes Dr. Gregoire and his team have identified after they fix the problem that there's a marked difference in the way the patient is functioning. And so in the emergency department setting, that puts us at a disadvantage. We don't ask questions in that detail, and we may underappreciate the importance of those symptoms. When the patient has these severe symptoms, including nausea, we need to be considering hypertonic saline a little bit earlier. I know there was a lot of concern about central pontine myelinolysis, and we still need to be watchful and thoughtful of that. But if we're on the fence of giving hypertonic saline, Dr. Gregoire mentioned that mini boluses of 50 to 100 cc's of 3% saline and then reevaluation of your patient and their symptoms can be very helpful. There is a lot of consideration of acute versus chronic made in previous evaluation and management strategies of hyponatremia, but this is progressively being phased out. Acute and chronic is defined as 48 hours as the cutoff between the two. And with our long wait times and difficult access to care, it can be very difficult for us to know whether the symptoms or whether the condition is acute or chronic. So we have to really rely on when the symptoms started and maybe even begin treatment. In terms of testing for hyponatremia, we need to help our nephrology colleagues out by getting serum and urine osmolalities and sodiums in addition to everything else. And in particular, in very difficult cases, it can help them stratify the likelihood of an ADH-mediated process. Dr. Gregoire mentioned that people with a heavy consumption of alcohol or who may not be getting electrolytes in their diet, such as those who are eating a lot of tea and toast or the equivalent, people who are on medications like SSRIs, seizure medications, and thiazide diuretics are at risk of this, including those who might be older and have other difficulties that way. In terms of the serum values of consequence, we are stratifying hyponatremia into severe hyponatremia, which is essentially under 120, moderate hyponatremia, which is 120 to 125, and then mild hyponatremia, which is 125 and greater. Severe hyponatremia is best treated initially with an aggressive replenishment strategy or aggressive strategy to return to normal. Moderate, especially if they have symptoms, again, aggressively treat. And then calculations that previously we talked about, like a FeNA, fractional excretion of sodium, aren't as helpful anymore. Really, we want to focus on our history. And then if patients have hyponatremia, make sure to correct for hyperglycemia. Then we transitioned to hypernatremia. There's very limited danger, at least in the literature, according to Gregoire, from hypernatremia. And most of the cases have to do with patients who are extremes of age, very young or very old, and those who have some kind of difficulty getting to water, whether it's a physical restriction or they're on an intentional restriction of water or they're immobile or something. But it's a situation where people cannot keep up with their hydration most often. There is a free water deficit calculation, which is sodium divided by 140 minus 1 times the ideal body weight. And that can be very helpful to understand how much water these patients need. Usually you can determine the cause of hypernatremia by the history, and that urine osmolality can be very helpful to identify the cases of diabetes insipidus, which might be hidden in amongst these cases. And so we want to try and help by getting those urine values before any treatments are offered, if possible. The disposition for these patients really should be based on your judgment, whether they can be seen quickly, have good follow-up, have good support to go home and things are improving and you have a good sense of the cause, or if they need to be in the hospital. There isn't any algorithm for that. After sodium, we transition to the kidney electrolyte, which is magnesium. And interestingly, magnesium does not have any hormones that regulate its concentration. Hypomagnesemia is associated with cardiac arrhythmias, and in patients with kidney failure, we need to be very thoughtful in the way we replenish magnesium. Hypermagnesemia can lead initially to hyporeflexia, which we may not notice, but then progress to weakness. That is more limbs progressing towards the central trunk, and then eventually respiratory depression in extreme cases. The causes of hypomagnesemia really relate to PPIs, diuretics, chronic diarrhea. And in some very unique cases, a fractional excretion of magnesium might be used, but most often history is the most important. The treatment is complicated because the more we give oral magnesium treatments, it can precipitate more diarrhea, making the situation more difficult. And so we want to recommend, if possible, patients eat more green leafy vegetables, nuts, legumes, and dairy. Certainly there are medications that we can use, especially IV magnesium as well. After that, we touched on phosphorus, and really this is important for ATP and energy, and extreme hypophosphatemia can lead to anemia and weakness. The causes of hypophosphatemia really, again, diarrhea, malnutrition, and the treatment, really we want to recommend, if possible, that they replenish this with their diet through dairy and grains. Even Coca-Cola or other sodas can be helpful. There is KPhos, which can be given orally and or IV. The degree of hypophosphatemia is really much more important when the values are under 1.5, but there's a lot of room to allow for outpatient follow-up or inpatient care of this. Hyperphosphatemia, we're talking really over 10 or over 15, and is often caused by kidney disease. And when that's the case, treatment can be usually with a low phosphorus diet plus or minus a binder. And then we also have to watch out for tumor lysis syndrome. And those patients, we will do a short trial of fixed diuresis, which can happen in the ED. And if they're not responding, they might need dialysis then. Okay, whirlwind tour of electrolytes. And we appreciate that you've all been sticking around for this. And Dr. Gregoire, thank you so much for your time and attention and help. in teaching us all this stuff. We're really, really grateful, Jim. You're just amazing as an educator.
All right. I wish you guys well.
All right. That's another wrap. Please make sure you come back October 1st for the next episode of Always on EM. As always, we appreciate any feedback. As I mentioned in the beginning, you can email us at alwaysonem@gmail.com or hit us up on social media. Alex, myself, Jim, we're entirely grateful for all of the energy you've given in listening to us and learning from us, and appreciate that you're doing this by your own choice, and we don't take that for granted. We hope you have a wonderful September, and we'll see you next time. Thank you for listening. The Always On EM podcast, hosted by Alex Finch and Venk Bellamkonda.